Good afternoon, everyone. I'm Christy Koenig, the EMS Medical Director for the County of San Diego. Thank you so much for joining us for the next lecture in our series of evidence-based medicine presentations. Today's topic is Key Controversies in Pre-Hospital Treatment. What is the evidence? And we'll feature 4 of our EMS physicians speaking on the evidence base for selected pre-hospital treatments. Each EMS physician has been asked to briefly summarize the current literature and provide their recommendation. References for each topic have been distributed with the EBM flyer, so you should have those already. The data presented today will inform our future protocol revisions. First, we'll hear from Dr. Fisher on sedation medications. This will be followed by Dr. Khan on the use of PEEP, then Dr. Sloan on the use of blood products, and finally, Dr. Vitalani on the use of amiodarone versus lidocaine for VFBT. We'll proceed through all the presentations and then open up the floor for discussion. We look forward to the presentations and your input during the discussion. So over to you, Dr. Fisher, for our first topic. Thank you.
Great. Thank you, Dr. Koenig. Give me 1 second to share my screen. Let's see. Go. Okay. All right. Can everyone see my screen?
Yep.
Perfect. All right. So again, my discussion is going to be about medication for sedation in the pre-hospital setting. I know this is a hot topic, especially given the recent Elijah McCain case, and also just the uptick or more media coverage being focused on patient death in law enforcement and EMS custody over the past few years. This presentation is a combination of the currently available data, also some of my anecdotal experience working with agitated patients and performing law enforcement medical clearance for now almost a decade. It's a quick talk, hopefully to stimulate some discussion for possible LOSOP in the future. I don't have any disclosures for this talk. Again, I won't be discussing ketamine or other terminologies. It's going to be focused on, other medication adjuncts to use. So going on to the first slide. What is the right med? It should be something easy to administer, non-traumatic, that quickly calms the patient without excessive sedation. Hopefully, again, not too much variability in its uptake, and the fewer adverse reactions, the better. And then in terms of questions to ask, oh, sorry, I realized my slide was out of order. The slide here, what I asked myself again before is, what's the right med? First, I asked myself, why is this patient agitated? Is it because of an underlying psychiatric disorder? Or is it because of recreational drug use? Or is it because of alcohol or suicide? Is there some component of pain or hypoxia or shock? Again, if this is someone who's in pain or shock or hypoxic, you want to address those underlying conditions first before trying to aggressively sedate them. If you're dealing with a drug overdose, intentional drug overdose, some drugs in high doses can cause agitation, such as diphenhydramine or TCA overdose. Those would be instances you would want to avoid giving someone diphenhydramine for sedation. Also the age, extremes of age, pediatrics and geriatrics, there always should be more concern and more kind of caution with what agents are used to sedate them. Going on to my next slide then. Again, I already discussed this. You want something that's easy to administer, sedates the patient, does not have too many side effects. Our current options right here in San Diego County is mostly midazolam and midazolam. The best route, as mentioned in our previous lecture, intramuscular is currently the safest route of drug administration for severely agitated patients. IV push benzos, antipsychotics, ketamine, any of those medications given IV increase the risks of respiratory depression, hypotension, cardiac arrhythmias. These are risks that seem to be somewhat documented less frequently in the literature when given IM. Also, establishing IV or IO access is usually impractical in the pre-hospital setting. In the future, there are some inhalation drugs that are promising, such as inhaled loxapine, which is an inhaled first-generation antipsychotic, but it's brand name only and requires some patient cooperation, which, again, probably not the best solution right now. In terms of the solutions we do have, again, here's midazolam, our standing order, which can be given 5 milligrams IM or intranasal IV. We do have diphenhydramine, which is in our standard scope. This would be a variation more for sedation. The nice thing about diphenhydramine, which I usually, when given for sedation, I give 50 milligrams. It is IV, it's syringe compatible with midazolam. So if you have someone very agitated, you can pull up the Benadryl and midazolam in a single syringe and administer it. The onset is a little bit faster than midazolam. It usually has an onset of 5 to 10 minutes. It has a good safety profile with alcohol intoxication, not causing respiratory depression. It's safe to also give to fentanyl. So if you have a trauma patient who's mostly pain, but also some agitation or anxiety or nervousness, it's safe to give with fentanyl. Your risks are geriatric patients. Again, the anticholinergic properties of diphenhydramine might make agitation worse with them. Also, with drug overdose patients, there is a risk and should be avoided. Going on to the next, and then also just again, I'm sure many people are familiar with the classic B52 combination, which was 5 milligrams of Haldol, 50 milligrams of diphenhydramine, and 2 milligrams of lorazepam. It's been always a combination that's been noted in literature for decades now. And what I always find interesting is usually the first medication that takes effect in that combination is the diphenhydramine, as lorazepam and Haldol both have sort of variable, kind of somewhat more prolonged onset of action when given intramuscular. So for this talk, for LOSOP options coming up this year, there's 3 medications I looked at, was haloperidol, Haldol, droperidol, and olanzapine, also known as Zyprexa. These are generally considered some of the most sedating antipsychotics with a fairly rapid IM onset of action. Just kind of doing a brief table. Again, this is just loosely summarizing some of the literature, the level of sedation. Everyone has their own personal favorites. Literature-wise, level of sedation has been pretty comparable on these 3 medications. The IM onset of action is a little bit slower with haloperidol compared to droperidol and olanzapine. Droperidol might be a little bit faster than olanzapine when given IM. However, you do have much more black box warnings with droperidol. It has a manufacturer contraindication for prolonged QTC or suspected prolonged QTC patients. It was taken off the market for several years due to concerns for its QTC prolongation effect and possible cause of torsades. Again, regardless of where you stand, I think with the data on the risks, and again, most of those risks were associated with IV administration, not IM. It is something that is out there on the internet, and And again, as we are seeing with this recent Colorado case, there's some court of opinion is probably something that it is prudent to take into consideration when picking a medication for pre-hospital use. Haloperidol has some biggest risks are it's more likely to cause extrapyramidal side effects. Olanzapine, its biggest warnings right now are with combined use with benzos, causing respiratory depression, hypotension, which I'll get into. Again, the biggest advantage of olanzapine is it comes in multiple variations. IM, PO, oral dissolving, now nasal, and there's some research stating that it's safe to give in IV formulation. So my pick was olanzapine. Again, it's currently in low stop for Alameda, LA, and Tulum counties, and also the Northern California LEMSIS. El Dorado has nitric oxide on their low stop, but that's for pain only. The benefits of olanzapine, it's simple dosing, rapid IM onsets. Usually if I'm sedating someone who's very agitated, combative, I just go straight to a 10 milligram dosing. The name recognition I found anecdotally to be somewhat useful, as many psychiatric patients are familiar with this medication and are usually willing to take it. If you tell them, can I give you a shot of Zyprexa, they're usually familiar with it and usually pretty amenable to taking it, or even willing to take it as the oral dissolving tablet, which has a pretty rapid onset of action of about roughly 30 minutes. Those patients have to be cooperative. Possible drug combinations for this, for sedating in pre-hospital, again, our standard scope, standing order, the 5 milligrams IM midazolam, which again, you can add 50 milligrams IM diphenhydramine in the same syringe. If that does not work after observation, you can give, again, in the ER, I've been giving this combination of 5 milligrams IM midazolam and 10 milligrams IM olanzapine for years without ever having any serious, any adverse, major adverse effects. And I'll go into the literature on the next slide on that. Again, I've had some severe patients where I've had to give a total of 10 of midazolam and 10 of olanzapine. Not as frequently, but it does happen. And again, you can add diphenhydramine to any of these combinations. When dealing with patients who are more alcohol intoxication, I usually refrain or more hesitant to use the midazolam and might just go with just the IM olanzapine, which is usually enough to make a disgruntled, angry drunk into a more placid, semi-cooperative drunk. And again, you can add Benadryl to that as well and do a combination of, say, olanzapine, diphenhydramine for someone who you suspect is mostly agitated due to alcohol intoxication. In terms of the safety, olanzapine does not have the same negative connotations for causing sudden cardiac death as some of the first generation antipsychotics. It does not have a black spot warning, recommending ECG monitoring prior to administration, which unfortunately is the case with droperidol. Patients with severe agitation in the pre-hospital setting already have an increased risk for sudden cardiac death from the data that we have currently. Risk mitigation, all things being equal, IM olanzapine may be perceived as safer, whether that is supported or not. That is probably a consensus that many people have at this time. Other counties in the state have already implemented LOSOPs for olanzapine. And it's a fairly effective drug. The big things, again, are the sedation with concomitant benzo administration. However, they've done some studies I was looking at, they showed that even ketamine IM had a higher incidence of requiring invasive airway placement than either antipsychotics or benzodiazepines. The FDA published the warning of co-administration of olanzapine and benzos after there was 29 deaths reported associated with this combination. However, this can be mitigated with, again, continuous monitoring, pulse ox, and tidal CO2, keeping your eyes on the patient. Going over a brief table of those fatalities, almost all of them were associated with olanzapine, benzo, and other meds, specifically alcohol. Most of these adverse events all occurred with patients who were heavily intoxicated. And when you took out the alcohol component, the incidence of hypoxia was significantly less. There was only 4 out of the 29. There's been some studies that have used this combination and have without noticing any increased risk of airway compromise. I believe some of these studies I saw, Dr. Vilk was one of the authors on them. Patients with alcohol on board have a higher risk of hypoxia when administered with any combination, actually ketamine, benzos, opioids. This isn't really unique to olanzapine. It's any kind of sedating drug mixed with alcohol causes a higher risk for sedation, respiratory depression.
Please wrap up the next minute.
Yeah. So again, just my last slide, really, pre-hospital sedation, again, a reminder is, you're basically giving rapid chemical tranquilization, which is critical care. Patients need continuous monitoring, airway, breathing, circulation, pulse oximeter, and tidal CO2. Again, just looking at the slides and presentation from the recent Eli McCullen case, EMS needs to control the patients, law enforcement controls the scene. It's, again, EMS's duty is to patient care, not assist law enforcement. It's important to document vitals or some objective of exam findings when administering sedation treatments. And kind of a nice slide they mentioned on this presentation Dr. Koenig sent out a week ago was, again, being a compassionate provider never led to an arrest or to a courtroom. Hopefully, I like to think that stays true today as well. So again, that is my my sort of cliff notes on pre-hospital medications for sedation.
Thank you so much, Dr. Fisher. That's a really challenging topic, and appreciate your emphasis on safety and efficacy of these various interventions. We'll turn it over now to Dr. Khan to speak on PEEP in the pre-hospital setting.
Alrighty, let me just get that pulled up. There we go. All right, so this is going to be very brief. I've got a 5-minute time slot here. So we're talking about PEEP, pre-hospital, or I guess PEEP, pre-hospital positive end expiratory pressure. And so the basic concept, I think folks are aware, you breathe in, you expand your alveoli. When you breathe out, those alveoli contract down, but ideally they would still stay open because the force it takes to open an alveolus is a lot more than the force it takes to keep it open. So some folks who have conditions, atelectasis, other things that make it a little bit more likely for the alveoli to contract all the way down to collapse, would benefit from PEEP. So that's pretty much the entire physiology right there. Then the question is, well, that sounds great. Should we just use it with everyone? So we can use it with most folks, but there are some contraindications. There aren't any absolute contraindications, but the relative contraindications, there is one for elevated intracranial pressure, because theoretically you could decrease your cerebral outflow, which would then increase your intracranial pressure further if you're increasing the pressure in the chest. There is some theory that with focal lung disease, like pneumonia, for example, if you're putting some excess pressure on normal, healthy alveoli, you're compressing those capillaries a little bit, so some of the blood flow would go to the injured lung, which could decrease oxygenation. Honestly, neither of those are big worries. And I'm not really aware of anyone who looks at those as, nope, absolutely can't use it. The contraindication that is much more relevant to us is hypotension. So when you increase your intrathoracic pressure, which, as you can imagine, happens if you're increasing, that the pressure inside, that's exactly what you're doing, right? You're increasing the pressure inside the chest, usually by about 5 centimeters of water. So that decreases venous return. That reduces your cardiac output. If you're already hypotensive, especially if you're hypovolemic, then you're likely to worsen hypotension. So that really is the contraindication that we need to keep in mind, and that is reflected in our current protocol. Some folks have also heard of a thing called auto PEEP. This is more of you think of this more in asthmatic COPD patients. This is something where it takes them longer to breathe out, and the next breath starts before they've finished breathing out. So you start trapping air and then trapping a little bit more air. You can do this while you're conscious, although it's really difficult, but more commonly this happens with positive pressure ventilation. So either you're putting in a lot of volume or you're breathing quickly, or both, especially if there's some limitation to expiratory flow, like bronchospasm or a kinked tube, or of course a PEEP valve by definition is resistance to expiratory flow. Now there is some, because physics is weird, you can actually, if it's just a question of bronchospasm, you can actually stent the airways open a little bit with a small amount of PEEP. But really the main thing to keep in mind for auto PEEP, and incidentally, this is what comes to mind when I think of auto PEEP, but it's because that's just how I work. The main thing for auto PEEP is that if you're using a PEEP valve and you're finding that, wow, it's getting harder to bag this patient, then ditch the PEEP valve. If they are intubated and you've got a bag connected, disconnect that bag. Maybe even squeeze the chest, because what's likely to happen is as soon as you open that circuit to the ambient air, you'll hear kind of air coming out, and squeezing the chest can actually help release some of that trapped air. And then you'll find that your ventilatory compliance improves. So those are some of the edge cases. But when it comes down to like, what's the optimal PEEP for most people? So this is one way of looking at it. But if you prefer that in numbers, then I would say PEEP is honestly, it's a good idea on most patients. This is something that we routinely use in ventilated patients in the emergency department, in critical care units, during critical care transports. The literature suggests a starting range of anywhere from 3 to 8, but 5's in that range. 5's easy to remember, and all of our devices, because we usually are not using monitors where you can just precisely dial in a number. We're usually using the PEEP valves. Like, well, it's on a spring and I'm going to twist it and see where we get. All of those can do 5 really nicely. So basically, I would start with 5 of PEEP on someone that you're providing positive pressure ventilation to, who is not hypotensive. If they're still hypoxemic, I would increase it. Now, if the oxygenation or ventilation is getting worse with PEEP, then I would consider decreasing it. But bottom line, do keep in mind that the pulse ox waveform, that plethysmograph, it can take a solid 45 to 60 seconds to actually catch up to reality. So I would not say, oh, I put a PEEP valve on, I've given them 3 breaths already, how come their oxygenation isn't improving? You got to give it some time for the pulse ox to actually catch up. That is really it. There are some references here, including that third one down is the position statement from our National Organization for EMS Physicians, that goes over some of the resources and talks about different, really all sorts of things on pre-hospital airway management. And I believe Dr. D'Onofrio Odman also has something coming out shortly on pediatric airway management. But this document does discuss PEEP a little bit. The vast majority of this literature is all really in the ICU space. But I would say, going back up here, PEEP is a good idea if the patient is not hypotensive. I believe we're saving questions for the end. So I'll take a look at the chat, but in the meantime, I'll stop my sharing and I will hand it over to the next person.
Thank you very much for that helpful overview and your recommendation, Dr. Khan. We'll now turn it over to Dr. Sloan to talk about the use of blood products in the pre-hospital setting.
Okay. All right. Cool. Thanks. Let's get this thing rolling here. Rock and rollin', rock and rolla. See if we can get her swept over. Zoomarooski doobob, share screen. And we are going to that. Okay. Share. And I presume that's working. Cool. All right. So just wanted to talk a little bit about this. Any of these topics, you could talk about a heck of a lot longer, and we've only got a few minutes, so I'll try and be brief. These are the things that we can do that we need to address in pre-hospital trauma. These are the immediate life threats. One of the ones there highlighted in red is hemorrhage, and we have options of either stopping it or stop and replace. And so that's probably the people that we're going to be talking about in this case here. First studies that looked at the use of blood in the pre-hospital, sort of the first ones that you got really big notoriety were the both of PROMPT and PROPER. And PROMPT was a big multi-center study that showed that basically the faster that you got blood on board, the lower the mortality for patients who required blood transfusion for hemorrhagic shock. And then PROPER started to define what's the optimal ratio. And they are the ones that put forward that it really was going to be a 1-to-1-to-1, meaning 1 unit of packed cells, 1 unit of plasma, 1 unit of platelets is the most beneficial. There's been a lot of studies since then looking at this. Some focused on pre-hospital, which tends to be air medical studies that are using a helicopter, because it is a valuable resource and typically not needed quite as often. And so that's where people have chosen to put it initially. A review of Europe's data shows that they've been doing this for a while. In France, they have uptake of about 89% of their units will carry it. I thought it was interesting that 94%, that top line there, of units in Europe use tranexamic acid. So I'm glad we're finally catching up with Europe here. And, you know, most of them felt that it was beneficial and can be done safely. So there's my thoughts here, just briefly, without going too in depth into all of the literature, is that the use of pre-hospital blood transfusion does make intuitive sense for a certain population. And I think that defining that population is going to be the key for any system that decides to use it. In a system that's got unlimited resources, it makes obvious sense. But unfortunately, that's not the world we live in. We don't have unlimited resources. So we have to balance all the things that we have that we want to do with the things we have money for. I think that you can say that there's good evidence to suggest that pre-hospital blood transfusion is safe to perform in the pre-hospital environment. That can be done safely with good systems. That time to transfuse seems to be the key factor associated with increased survival. It is better than crystalloid in trauma resuscitation of hemorrhagic shock patients. That systems can be developed to support the use and implemented by pre-hospital agencies. That can be done. And that there's a good group of patients that have very good evidence that it's beneficial, and it's trauma patients in shock. in whom ongoing hemorrhage can't be achieved. So this is not somebody who's got a penetrating extremity injury that you can put a tourniquet on. This is a different population. Typically blunt trauma patients who've got trauma to the chest, abdomen, pelvis, or long bone, or penetrating trauma to the torso. I think that's probably the group that would benefit the most. Whole blood is preferred, since most agencies are not going to be carrying multiple different components, and it would take time to get those in anyway. There is some evidence to suggest it might be useful in GI bleeds and OB hemorrhage, but in that literature, we tend to have a more restrictive strategy when it comes to blood transfusion, and there are some negative effects associated with unnecessary transfusion, so it's probably a little bit more limited in that setting. A couple considerations. I think in our system, the patients that would benefit the most are those who have long transport times and the above indications, i.e. hemorrhagic shock, that have blunt trauma. And so how many ODEs do we have that aren't currently flown by helicopter? I think we need to get some more data to better understand the scope of potential use of something like this. There is a significant cost associated with these programs, and that has to be factored in when we're factoring in all the things that we'd like to do. Certainly not as cheap as a PEEP valve. It's not practical to put blood on every ambulance in San Diego County. It's just not. We have too many. But maybe we could go to a more tiered dispatch model where certain units would be sent to calls that might have the potential for use. That would be something we could look at. We would want to make sure that we avoid waste, that each unit of blood has a finite lifespan and it has to be stored in controlled conditions. That can all be done, but we have to take that into account. I think that while it's nice to talk about it here, there's people who aren't here that would need to be involved significantly, such as the trauma surgeons, blood banks, and those folks. So it's going to be a multidisciplinary decision to decide to do something like that. And another consideration might be is that we could consider strategic placement of blood transporting ambulances to those units that historically, based on data review, were most likely to have encountered those kinds of patients that could benefit from it. Also taking into account what we need to pay attention to, which is equity concerns with any intervention that we choose to implement. That's my brief review of a very extensive topic with the thoughts that I had, and I'm sure we'll have more discussion at the end of the presentations.
Thank you very much, Dr. Sloan, for your extremely thoughtful analysis. We'll now turn to our final presenter, Dr. Vitalani, on the use of amiodarone and lidocaine in VFBT.
Great. Thanks, everyone. Unlike my colleagues who are much better prepared, I did not do any slides, but I do have some things to show you. So let's see here. So, you know, if you're ever looking for the data on anything cardiac arrest, the nice part is there is a international organization that has done all the deep dives for you, way more than any one individual could ever do. It's called ILCOR, or the International Liaison Committee on Resuscitation. And if you've never gone through their consensus on science with treatment recommendation website, I encourage you to do so. The nice part is they sort of prospectively, as new trials come out, individually read through them, critically appraise them, and then sort of add them into the current body of literature. So if you're ever curious about drugs that you've never heard of being evaluated versus drugs that you have heard of, this is a great place to do so. So we're looking at amiodarone versus lidocaine, so specifically for VFVT, and more specifically refractory VFVT as per the ACLS guidelines. You know, for those of you who have sort of always preferentially had one or both, there has been some studies in the past 5 so years to try and determine if there is one that's better, and if so, which one it is. And so, as I mentioned, the real question becomes, you know, amiodarone, lidocaine, or nothing. And then if there is amiodarone or lidocaine being better, which one's better? And so most of you are probably familiar with the big ALPS trial in the New England Journal of Medicine. That was published by the Resuscitation Outcomes Consortium. You know, bottom line up front, essentially, amiodarone or lidocaine, either or, are better at giving you return to spontaneous circulation, but not neurologically intact survival. So they improve ROS grades as well as survival to hospital discharge, but not neurologically intact survival. So again, it really depends on what your individual outcome is that you're looking for. And it's best summed up in the summary here. Survival rate, amio versus placebo, lidocaine versus placebo, and amio versus lidocaine. Essentially no difference between the two drugs, but a overall predominance towards some survival benefit in the antidysrhythmic group of the study. Interestingly, there was a subset analysis done a little while later by some of the ROC investigators that looked at whether there was a difference if those drugs were administered IV versus IO. And again, what they found is that there is not a specific difference, although in the amiodarone subgroup, if given quickly IV, there might be some survival benefit. But like with most studies, if the study itself is not powered towards one individual outcome, it's really hard to draw any specific useful conclusion based on the individual study itself. And so for those of you who are from up to date with your guidelines, you will have seen that as per ACLS, they really just put in amiodarone or lidocaine. And I really, for the most part, agree with this recommendation. Based on the current body of evidence, there's not anything to say that amiodarone or lidocaine is better than the other. I would say that there is maybe some benefit to giving it IV versus IO, and then there's maybe some benefit giving it a little earlier, especially in witnessed arrest, which honestly are sort of almost contrary tasks sometimes. Trying to give a IV drug quickly compared to an IO drug or slowly, those are typically switched around. IO is oftentimes faster than IV placement, especially in difficult IV access patients. So that's the predominance of it. The good and the bad of this is, unfortunately, there really isn't a lot more evidence available, or any high quality evidence available for the antidysrhythmic drug sort of conversation in the first place. As I mentioned before, Alcor has looked at all sorts of things in terms of various antidysrhythmics for this, but even their sort of suggestion is that we suggest either amio or lidocaine, but not really one versus the other. And that all sort of exists in the adult population. Moving to pediatrics in a very similar way, the data is lacking, but in the pediatric population, like with a lot of things, even more so. And so really, there's only one decent study looking at amiodarone versus lidocaine in the pediatric population. And essentially what it shows is that there's no difference between them. And thus the recommendation is typically use an antidysrhythmic, but amiodarone or lidocaine is really up to you. And so there's really not a whole lot more to it. So I guess that's all I got.
Wonderful. Thank you very much. We'll go ahead and open it up for questions and comments at this point. There is one question in the chat regarding the first presentation. Tyler, do you want to read that one?
Yeah, we had one question from Don Sullivan. He was referring to the use of benzodiazepines and antipsychotics. He wanted to know, would these tools be useful for anxiety as well as for agitation?
Sure.
So for anxiety and agitation, it's definitely, you have some patients who are fairly anxious. They have, say, a bad trip from the first time using marijuana. I've given ODT, olanzapine, and that's, or again, a benzo Versed, and that's helped them kind of get over the anxiety and kind of fear of, going through having say like wax or THC wax, or just any anxiety. Either of those agents do provide sort of a calming effect. Also patients with formication, they just feel like they're having bugs crawling over, or having visual auditory hallucinations, and they're somewhat cooperative. You can give IM, or again the ODT, olanzapine, and it's pretty effective and provides relief for them.
Thank you. I'll just remind us that for a LOSOP, a local optional scope of practice, that we need to use the drug for whatever we specify that we would use it for. So if we applied for a LOSOP, for example, for agitation, but did not say we were using it for anxiety, in a LOSOP, we could not do that. Once something moves into basic scope of practice, that's a whole nother story. So please raise your hand if you have any questions or comments, but I do see some more popping up in the chat in the meantime. So Jen, you look like you were first if you want to ask your question about PEEP for Dr. Khan.
I could verbalize it too, Dr. Koenig.
I'm just reading through it right now.
Oh, go ahead.
So it's a great question if we should be using PEEP in CPR patients, since the hypovolemia should be corrected. I reached out to some of our critical care colleagues. They tend to not use PEEP during CPR because of the concern about impeding venous return and decreasing cardiac output, especially when there might be something like a pseudo PEA where you're not quite sure if the pressure is just really low or if it's actually zero. We talked about physiologic PEEP. Technically 0 is physiologic PEEP, but 5 is generally considered what would best match the recoil of the chest if they're having breathing issues. But given the risk for hypotension, our critical care colleagues, at least at UCSD, tend to avoid it. I don't know if other physicians on the call have different experience with their ICUs.
Thank you. I don't see any hands raised, but I do see Dr. D'Onofrio is not in a position to speak and put something in the chat that says our peds cardiologists have a preference for Lido over Amnio due to side effects, not evidence-based medicine, but good to know what the specialists within your system prefer. Dr. Vithalani, do you have any comments on that?
No, I defer to my very well-respected PEM EMS colleague.
Very good. And Mary Murphy, please go ahead. I see your hand up.
Thank you. Dr. Villani, we're currently required to carry both lidocaine and amiodarone for our CPR patients, with no guidance as to which is better to give. And I'm wondering, do you have guidance which is better to give? And if that's something that we can clarify maybe in this upcoming year's protocols.
Yeah, so I wouldn't say that there's any guidance, at least not evidence-based guidance, and I would definitely defer any formal guidance to Dr. Koenig. I think, looking at the data, there's not really one versus the other. I would say that there are, when there aren't clinical differences, there are oftentimes logistical differences, the most notable of which is which one can you get your hands on? Also, whether there's one that's easier to administer or maybe your crews are more familiar with. In the absence of any clinical, guidance, I would just say that those are other things to take into consideration, in that decision.
Yes, those are good points. So we're all dealing with the drug shortages, and in some cases we do have a preference. For example, for pain medicine, we prefer fentanyl over morphine, but we might not always be able to get fentanyl, so it's another option. But this is exactly the reason we wanted to review the literature on these antiarrhythmics to see what the actual scientific evidence is, so that we can factor that in when we look at operational conditions as well. Thank you. Dr. Sloan.
Yeah, no, it was going to be my comment, especially with the drug, these two drugs in particular, Lido and Amio, no benefit one or the other over the other. It's nice to have it in scope as an either or option to have, but I'm not sure it makes a whole lot of sense to require the carrying of both just because of the mentioned items above.
Thank you. Anybody else have questions or comments? Mary, is your hand up from before, or did you have a new question?
No, sorry, I'll lower it, sorry.
No problem. Are people convinced by the recommendations of the 4 presenters, or does anyone have other opinions?
For just one person's opinion, I think adding something to our formulary for sedation is a great idea. I think olanzapine certainly a reasonable choice. I think droperidol would be a reasonable choice. I think there are several reasonable choices, but we do see that midazolam does not always work, and there are some patients which midazolam may be a bit more likely to cause some respiratory depression, like some of our intoxicated patients. I would love to see moving towards as Dr. Sloan, very eloquently stated, we can't put blood on every EMS unit, but I think there are some where it would definitely be helpful. And I understand the concept of, oh, you're only a few minutes from the trauma center. Everything's always just a few minutes. Why don't you just drive faster? But even a few minutes of hemorrhage can be a few minutes too many. And we've seen in other systems where there have been significant changes in mortality rates, like improvements, let me be clear on that, through implementation of a pre-hospital blood transfusion. And when it comes to amio versus lido, again, I think Dr. Sloan hit the nail on the head, which is we should pick one, and even if we end up carrying different things at different agencies, we really should not need to carry both.
Thank
Thanks for
you.
the opportunity to discuss it.
Anybody else have comments or questions? Dr. Sloan.
But again, my hand is back up. I appreciate the format. For Dr. Fisher's point, I think that we all are very concerned about patient safety, but the second part of that is first responder safety, and trying to calm somebody who is incredibly agitated and violent with multiple small doses of medication can be incredibly dangerous for first responders. So anything that's more effective with lower doses or less frequent administration probably would be a huge benefit to first responders. With the carrying of the blood products, I'd be interested to speak to units that are already doing that and figure out how they're accommodating that within their ambulance in terms of refrigeration and stabilization of the product. So I think that'd be an interesting thought to look into, just because I would imagine we'd have to amend how we're, like a car, when you turn the power off, you turn the power off. So I think that would be a very interesting to look at the actual cost of doing that. I'm not sure what that would involve.
Two excellent points. Thank you very much.
Yeah, Mary, it's doable. The blood can be safely stored in a cube. They make cubes that are thermodynamically stable in order to carry the blood products around so they don't go out of temperature range, so they continue to be used and then return to refrigeration when the unit's out of service back at base. I wish, that we could somehow move forward with, I think that ketamine is probably the best drug for sedation. I agree with Dr. Schultz. There's just too much hot potato stuff with it right now in order for us to do it without more, I guess, evidence, that unfortunately. So I'd like to see the state or somebody come up with a study where we can compare it and use it for the indication of sedation. It just my experience in the emergency department, it is much better than anything else at achieving what we really want to achieve, which is turning the furnace off, the agitation and the things that lead to patients' increased temperature and acidosis and bad outcomes. And also safety for both staff and the patients so they don't hurt themselves. I think that's key. With regarding the blood, what I would like to see is the county put forward a request for a LOSOP and then let agencies that are interested in pursuing it, sounds like Dr. Khan's interested, figure out how he might be able to deploy that for the most benefit in his agency based on the data where he thinks it would make the biggest impact. So I think that's what we should do. Not mandate everybody carry it, but say, hey, this is available to you. If you want to put in the work and do it, go for it, because I think it helps people. That's all I have to say.
Thank you. And I think what you said before about not wasting any blood is also important. We're experiencing blood shortages in the community. So using it in the pre-hospital setting, we would want to make sure that we're actually using it. I will also point out that there's a difference between something called a LOSOP and something called a trial study. And not all of these interventions will necessarily qualify for a LOSOP and would need to be done as trial studies, which are a lot more rigorous and resource intensive. So just so people are aware of that. Dr. Schwartz, I see your hand.
Yeah, for our sedation, whether it's ketamine or the midazolam or whatever we are using or will be using, we probably should consider adding something with regards to contraindications and also minimal monitoring. Define that just to protect ourselves. I don't know what Aurora has changed since their incident, but I think we could probably think of things to put in there that would help us in that regard.
Thank you. And in the chat, Roxanne noted that the problem with returning back to base is that our units aren't really getting to go back to base as often as before. Very true. Other comments or questions? EMS team, did I miss anything in the chat or any hands?
I think you got them all.
Last chance. Any other comments or questions? Dr. D'Onofrio, you're able to speak?
I had to go hide. Sorry. We talked a lot about medications, but I didn't know if the county was going to put anything forward, maybe in PAC pearls or something, about with the highly agitated patient, the need to have good coordination with law enforcement, but also that you're taking over as their provider and they are your patient and the patient's safety and making decisions. Because I know ketamine was put on trial, but really when you look at the details, it was really about caring for your patient. And above all else, regardless of what medications we put out there, it always will fall back on the medics to truly do a correct assessment and treatment of their patient.
Good points. Thank you for that. Other questions or comments? All right, we will wrap this up. I want to again thank all of the presenters. I gave them an impossible timeline to synthesize a huge amount of literature, and they all stepped up to the plate. So really appreciate it, appreciate the discussion, and we will talk more as we work through our protocols. Thank you very much. We'll go ahead and break now.